Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Thank you for joining us for another episode on the INS Infusion Room. Today we have expert guest Cheryl Campos, and she'll be discussing intraosseous devices and her recent involvement in some work around these devices. Welcome, Cheryl.
Thank you, Derek. Thank you for having me. I'm honored to be here today. I have the privilege of co-authoring the joint position statement with the INS and the ENA and for the role of the nurse in the use of the intraosseous vascular access device. And I hope today that I'll be able to share some of my background and experience in that, ways that we have implemented the use of IO in the clinical environment, and some real lessons on why it's so important that this be done and why now.
Absolutely. There's a lot of great topics that we're going to discuss today. But before we jump in, do you mind to define what an intraosseous device is or intraosseous access is?
Yeah, so intraosseous access is basically taking a hollow needle and drilling it manually or with an actual drill into the bone marrow space in a long bone to infuse medications, blood products, or IV fluids. And historically, it has been done in pediatric patients during cardiac arrest, but we now know that it's such an effective tool and way of administering life-saving medications that it has expanded into being used in adults and not just during cardiac arrest either.
I think when you say the word needle and bone, sometimes nurses are a little squeamish or maybe hesitant. We've had these conversations offline, but I think the advancements have come a long way from what they used to be, though, right? So those nurses that are maybe scared of this device, tell them what it used to be like.
So I started emergency nursing in 1992. And at that time, I was very fortunate to work at a county hospital that was a training facility. And so I walked in as a novice nurse, knowing nothing, and walked away very confident and grateful for having been in such an environment. But in that time, I got to see a lot of very interesting things. And at that time, in the early 90s, what we used was something called a Jamshidi needle, which is kind of like Kleenex, a brand name, if you will. But it looked like a doorknob, actually, with a needle coming out of it. And the way that it was inserted was basically pushing pressure down and twisting back and forth until it broke through the bone and the access to the marrow was achieved. And you then put an IV tubing and are able to connect that to the needle and infuse the medication, etc. So that's kind of where it was, and in the early 90s. And it wasn't used very often. And when it was used by the emergency department physicians. And even over the years, as things got less barbaric, if you will, there has always been, at least in my experience as an emergency nurse, hesitation to use it. And the reality is it's actually very effective with few complications, and it should not be something that is only used as a last resort. In fact, I advocate for having it be your first choice when you have a patient that does not have visible, palpable veins and they're either in extremis, pre-cardiac arrest, and or need life-saving medications and fluids, and prevent that event from even happening.
I think you say a good word there, prevent. And That is so important. Also, delays in care that you mentioned, I think, is a super relevant and important in this discussion, is because, we see the hesitancy within nurses and hesitating to do this, or maybe are a little nervous, or maybe don't have the appropriate knowledge to be able to access. What's current state?
So, one other thing to think about for my nurse friends out there that are uncertain or have not been exposed to this before, paramedics have been inserting these pre-hospital for years effectively, and patients would come in a cardiac arrest, as I mentioned, and that would be the route we would use to administer the medications and fluids. In fact, it was oftentimes the only thing available. And so why in the world would we not, as nurses, practice to the highest level of our licensure and do something like this? So the state of today, what I'd like to talk about next is the fact that it's an intervention that is underutilized. And I believe a lot of it is because there are just not good protocols, policies, training, and opportunities in place for nurses to get involved in this. And what I'd like to share is how I actually was able to lead the program to bring the training to the nurses in one of the emergency departments that I worked for back in 2017.
And what were you doing during that time? What was your role?
That was a crazy time. I was the critical care educator, and I had the emergency department, cath lab, outpatient infusion, diagnostic imaging, which is where our PIC and ultrasound inserting nurses were at that time. And I was also expected to do all of the new hire orientation, do the continuing education courses that were going on, et cetera. So it was a huge task, and it was certainly, I didn't have expertise in all of those areas, so it was a learning curve for me. But I was fortunate to be in an environment where the manager at the time of the emergency department pushed for the IO training of all the nurses, and we actually partnered with Teleflex at the time.
But was there, before we get into that, was there any event or anything that led to that decision?
I don't know. It's right when I first came to the hospital, and it was already sort of in the works. And so I don't know if there was history behind that. I do know that it was the first annual competency skills fair that I was hosting or doing as their critical care educator for that department. And so it was kind of already set up that this was going to happen. And actually, the manager had already written a nursing protocol to allow nurses to do this. A standardized procedure is more accurately what he had done. So I brought the team in, partnered with them, and they actually came with all of their product and their training models. And we did a super user, if you will, or a train the trainer model to get us started. And so that involved picking nurses from all shifts in the emergency department to learn this skill. And we had an intensive workshop day where we all were trained properly, and we had to, of course, complete all the skills validation checklist and whatnot, as well as the course content that was going to be required of the nurses. And once we had that established, then we put all of the nurses in the emergency department through the training. And at the time, it was about, I want to say, 65 or so registered nurses. And the requirement was they did an online training program ahead of time with, excuse me, if I recollect, there was a multiple choice question test at the end. And then we had them come to the skills day where they actually learned about the standardized procedure, when they will be allowed to utilize the intraosseous, and the process for getting signed off to demonstrate that they were able to competently, if you will. At the time, we called it competency versus skills validation. But anyway, allowed to actually insert. And so the intent was the super user, or the person who had gone through the formalized training, would be available at the bedside with the nurse when they actually got to insert in a live patient. And the physicians were also allowed to sign them off. So once they were trained in the classroom and then they went into a real life clinical environment and they completed the skill accurately, correctly per all the required steps and were signed off, they were then allowed to insert independently. And as long as they had been through that validation in the last 12 months, they could continue to do so.
Great. So what was the environment like after implementation? Do you have any?
Well, I'm glad you asked that because it's kind of interesting. So first I want to be clear, what we did and why nurses should start to bring this up where you're at if you're not already doing it. So this standardized procedure allowed us to initiate an intraosseous insertion in two different circumstances. The first was if two attempts to place a peripheral IV had been unsuccessful, or, and this is my favorite part, and this is what I believe all IVs should be, if the attempt to place a peripheral IV was believed that to be unsuccessful. If you've done an assessment and there's nothing, and you're like, I'm just going to be putting needles in this patient, then stop and go straight to it. And that would be if a patient's in cardiac arrest or impending arrest, or if they were in shock or evolving shock, meaning they were in extremis and kind of like the environment where we call a rapid response or preventing cardiac arrest. When the patient's getting to that point, that's when you should be able to insert this. And so how it evolved was we asked, the physicians said, this is great. We're on board with this. We want you all to be able to do this. Clearly, you've put a lot of work and time into this whole process, but we want to know when you're about to do it. So after they had gone through all the training and they'd been signed off, they're like, just come and tell me that you're planning to do this. And they would then be able to assess and go, yeah, okay, good, go ahead. And or say, no, let's do this first or whatever it be. So it became a little bit of a mother may I thing. And that's okay. Because you know what, we're partners, we're a team. And I think that if a patient is doing that poorly, your emergency department physician should be aware of that this is occurring and what's going on. Yeah. And it also, involved doing this in adult and pediatric patients, which was great. And when the program was brought to us by Teleflex, they taught the pediatric and the adult insertions. And so in our standardized procedure, they outlined, for the pediatric patients, they had to be between 3 and 39 kilograms. And then you'd use the EZ-IO for the pediatric patients. And then 40 kilograms and up, or 8 years of age and up, you would use the adult version. And this was kind of an amazing change because again, going back to the Jamshidi, the doctor would put this thing in and now I have this needle, and if it's inserted correctly, it's very solid and in place. And it's like, okay, how do we secure that now? How do we put a dressing around that? Like we were doing medicine cups around it and tape and gauze and all kinds of things. As this has evolved, now there's these beautiful supplies that go down, fit over top of the needle and secure it beautifully to the skin. And that's the way it ought to be. And it's fantastic.
So, Cheryl, tell me what happens when nurses don't speak up to advocate for the IO insertion.
Yeah. So thank you for asking that. My heart is broken when I think back over my career and how many, again, at the time in the 90s and the 2000s, when I was very heavily involved in emergency nursing, how many cardiac arrests or poor outcomes I was witnessed and was part of because, we just didn't know what we didn't know. And, today I'm horrified and I look back and go, oh my gosh, I can't tell you, I would be on one leg and my colleague would be on another leg and somebody'd be up at the arm. And we were sticking needles in babies and just doing anything we could to try to get access when even if it was the Jamshidi, the thing still worked, was sitting right there on the shelf, how many patients did not survive that? How much morbidity and mortality was increased because of our lack of knowledge, our fears that kept us from using it, and our, lack of training. And so that's really one of the reasons why I wanted to be involved in writing the joint position statement between INS and ENA, because we need to speak up. We as nurses need to raise our hand and say, this is not okay, and we need to do something different. And so one of the most powerful things I learned working at that county hospital was to have enough confidence in myself to be able to speak up. And what I give to other nurses when I would train them is I would say, if something is going badly and one person tries and another person tries, and you're just like, you know, to speak up and say, this is somebody's child. We need to do something different. This is somebody's father. It's time to let someone else step in and offer a solution. Don't just say, you're doing a terrible job, you need to stop, but say, hey, let's try this. This is not working well. Because not to say that we're not compassionate, amazing, beautiful people, but our reality is, in order for us to do this job, we have to put on a facade and be very professional and specific and do it. And sometimes we have this tunnel vision, and it almost takes somebody over here on the side to go, hey, guys, wait, this isn't going good. Let's do something different. And that's scary for a lot of people if you don't have that confidence behind you. And so, that's what I say to nurses. Have something that is going to flow out of your mouth. Hey, this is somebody's child. Let's do something different. How about if we, kind of a thing. Um, and then I wanted to also talk about the fact that it's actually IO insertion is relatively rare to have complications if it's done well. So I'm not saying just let anybody willy-nilly go in. I'm saying have a solid program. Partner with medical device companies or whomever is available to do this training, and not just do it once, but do it ongoing, and really build your program and make sure you have the devices available. And I have a little story I'll tell you of an event at the end. Do not let me forget. It's my final story to make sure you know that not everybody that you think knows what's going on knows. Um, but, one of the things that was very powerful to me when we went through that initial training was they said, we each, they meaning the people that came in and trained us, said we actually inserted these on each other. And what hurt was not the needle going through the skin and into the bone. What hurt was the infusion of the saline. And I was like, wow, first of all, you're really brave. I don't know if I'd listen. But it was kind of an eye opener. And I just think, gosh, I almost equate it to like when potassium is infusing. And we as nurses know that that's painful to our patients. And so we dilute it more, we slow it down, we do things to make it more tolerable for the patient. And so those things exist with the IO as well. You can use 2% lidocaine administration prior to insertion for your awake patients. Certainly, if they're in cardiac arrest, you're not going to take the time to do that. But the dosage, at least when we were doing this, was 20 milligrams for adults, or 0.5 mgs per kg on pediatric patients, up to a max of 20 milligrams. So those sort of things have to be well thought out and follow standard of practice. Evidence that's out there, etc. But those things are powerful for nurses to know, because unless you've had that inserted on you, or you've witnessed it enough to see, hey, this is a great thing and it is the right thing to do for our patients in these specific circumstances, you just don't know.
You can see on social media the different videos that I've seen in the military, them practicing on your sternum, and yeah, it looks brutal. That's really great that you bring that up. That the pain is more associated with the infusion itself.
Yeah, interesting.
That's very interesting.
The other thing you mentioned sternum. So in our protocol that we wrote, we were not allowed to do sternal placements, and also we were only able to do the proximal tibia on the pediatric patients, and then the proximal tibia and proximal humerus on the adults. So those things have to be very, very specific. And when you're training people to do this, they have to solidly know and understand this, uh, and of course do the correct process and procedure. Another thing I was very fortunate to do is I participated in a cadaver lab, and it was in, I want to say also 2017 in St. Louis, Missouri, if I'm not mistaken, at an Emergency Nurses Association conference. And they allowed us to do a number of different procedures, but one of them was the IO insertion. And that was an incredible opportunity to be able to do this in an environment that was safe, very respectful, and allowed us to have someone right there hands-on, one-on-one, showing us how to properly do this.
Tell us about the program today.
So I've since left the critical educator role at that hospital, but prior to leaving, I asked one of the physicians that worked in the emergency department if the program was still thriving, and he indicated that yes, in fact, it is. And what had evolved to is whenever there is a code within the hospital, there's always an emergency department physician and an emergency department nurse that respond. And he said that they've got it down now that the physician manages the airway, and then the nurse just goes straight to the IO if they don't have an immediately obvious IV access. And it's worked out beautifully because they're not in each other's way and they can each do their part and get things going. And that's actually helpful for nurses in an inpatient environment that aren't comfortable or used to responding and performing under such critical situation. They're not very good often at placing IVs to begin with, let alone under stress. So the nurse is able to very quickly establish IO to be able to administer the medications and treatments needed for the patients in these critical situations. And it actually ends up being very effective, obviously. I do want to make a point before I wrap this up here, and that is, as effective of a program as it has been, there were a lot of bumps along the way. Certainly it wasn't perfect and still is not perfect. And I mention this now because don't assume everybody knows what you have done, and having the key stakeholders at the table are so important. So I'll share an event with you where there was a code in the hospital and the emergency department physician and nurse went, they grabbed their jump bag, which they always take with them when they go. And typically in that jump bag is an easy IO kit. And what happened was when they got up to the floor and they were pulling it out to insert an IO, the kit was not in the jump bag. So the nurse ran all the way back to the emergency department to get one out of the bottom drawer of the Broslow cart in the emergency department, not realizing that we actually had 10 Broslow carts in the hospital, and in every one of them, the bottom drawer has the easy IO. And so had the nurse been aware that the nearest Broslow cart was simply down the hall, that could have been time savings, but also for the nurses on the floor that were caring for the patient, if they also understood, hey, guess what? We have a Broslow cart down the hall. I'll go and get it for you. You don't need to run all the way back. So making sure you include everybody in the process is really important. And then in the end, I wanted to bring up, partnering with the ICU and other units is so important. We would often bring a patient into the emergency department that had no access or poor access. And the best we could do at the time was to place like a 24 gauge. And we would hydrate the patient and fix them up and then deliver them over to the ICU. And the ICU nurses would complain and say, why did this nurse put a 24 gauge in this patient? They have perfectly good veins. And I say that because did they really think that we're not going to put a better IV in than a 24 gauge if we had the opportunity? No, actually, we have provided fluid hydration, and now the patient actually has some veins that are not in total vascular collapse, or we put an IO in, and now you have the opportunity to place a larger gauge at a better location to be more effective to continue treatment for that patient. And remembering that an IO is a bridge device, it's to get us to that point. So if you utilize it appropriately, appropriately, have people trained, have the devices available, all the things in place, and practice this. So you can't just train. I trained 10 months ago and now it's all going to go perfect. But you have all of those things in place. Then when they do get to the floor, they can be removed within 24 to 48 hours, I believe is still the outer margin of it. But as soon as you're able to place a more definitive device, you can remove them. And that is how it really ought to flow. So I'd say in closing, I think it's really important that nurses recognize the value of us using all the tools in our tool belt and speaking up and advocating and not just waiting until something bad happens, but to say, you know what, something bad will happen. Let's go ahead and take this opportunity to allow our patients the best outcome possible. And start recognizing that these processes, this an intraosseous can save lives. So let's make this happen. let's do this thing and change the way we've always done it and stop harming patients, please.
Thank you so much. And I think that's a good place to wrap up today's discussion. So I want to thank you again for joining us today in the INS Infusion Room. Today we discussed considerations with intraosseous devices with our expert Cheryl Campos. She's provided us with valuable insight. I'm your host, Derek Fox, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.